Greetings, everyone. Welcome to today's session. I am Lisa Council, the Chief Commercial Officer for Adaptix, and I have the great honor to introduce our speaker today to represent the Global Health and Purpose Summit, Dr. Elizabeth Hansen. Liz is not only an MD, but also a PhD. She is a pediatric anesthesiologist at Seattle Children's. She is the assistant professor at University of Washington, and she is here to talk with us today about Project Spruce, of which she is the founder. Liz, welcome to the session today.
Thank you so much for having me. Thanks for that introduction, Lisa. I'm really honored and grateful to be here to speak about our work with Project Spruce. This work is about reducing the impact of anesthesia-related emissions without compromising patient care. And as many of you know, the climate crisis is a health crisis. We already are seeing the impact of climate change on human health. This slide from the CDC illustrates the vast impacts on human health that we are already seeing due to climate change and global warming. This is coming from increased CO2 levels, rising temperatures, more extreme weather, and rising sea levels. It's important to note that there is no safe global temperature rise from a health perspective, and we need to do everything we can to reduce these impacts to preserve human health. So climate change, it's very complicated. There are many health outcomes that are being impacted, and those are illustrated here on this really wonderful slide from the WHO. So as I mentioned, we're seeing more extreme weather events and heat, air pollution, changes in vector ecology impacting infectious diseases, water scarcity, reduced food production, all of that is impacting on climate-related hazards. And we see, many vulnerable populations that are being impacted by this. As healthcare practitioners, we need to think about how this is going to play into our ability to deliver healthcare in a changing climate, but also the way that our health systems and facilities are contributing to this issue. So we know that climate change is impacting our patients, and we have to be resilient and able to deal with those increasing impacts on their health. But we also need to think about the ways in which we deliver that healthcare and how we can reduce the contribution to climate change and pollution that we have while we are delivering that healthcare. So this is somewhat of an emergency in healthcare. It's been declared as a code red. There are several publications and journals that have highlighted this and have called for action to reduce the impact of pollution and emissions from healthcare. So this is the couple of screenshots here from The Lancet, which produces a countdown on health and climate change every year or two. There's an entire section in the New England Journal of Medicine dedicated to this, and I encourage folks to take a look at that. There are always new articles there. And then on the right here is a call for emergency action to limit global temperature increases, restore biodiversity, and protect health from an emergency medicine journal. But this is just one of many, many publications calling for action here. So what do? We recognize that healthcare delivery is contributing to harm. If global healthcare were a country, it would be the 5th largest carbon emitter on the planet. In the United States, we are responsible for an outsized proportion of these emissions. The U.S. healthcare sector is responsible for about 8.5% of our national carbon emissions and 25% of global healthcare emissions, despite having a much lower percentage of the population than that. And this is directly contributing to disability and mortality. Estimated several years ago to be responsible for over 600,000 disability-adjusted life years lost and 70,000 deaths per year from healthcare emissions and pollution alone. It's important to people who work in healthcare that their hospital systems and health systems are responding to this and doing something to address climate change. So this is a survey from the Commonwealth Fund that asked clinicians and healthcare workers if this was important to them, and the majority felt that it was, and they wanted to work at a facility or a health system that took this seriously and was doing something about it. So what do we do? How do we reduce the harm? Well, thankfully, there are a lot of organizations and folks out there working on this problem that have provided resources and roadmaps for how to reduce emissions associated with healthcare. There are several organizations on this page. There are more out there. There is an annual conference called CleanMed that focuses on this, where folks can network and share solutions and figure out how to overcome problems and obstacles that they're facing. One that has been particularly inspirational for me is the Inhaled Anesthesia Climate Initiative and research coming out of Yale, led by Jody Sherman and her collaborators. And that specifically looks at anesthesia gases and their contribution to healthcare emissions, which is, of course, what I have been focusing on as a pediatric anesthesiologist. So when I first started at Seattle Children's Hospital, I met with Colleen Grohl, who was our sustainability manager at the time, and she showed me this graph. She had performed an inventory of our greenhouse gas emissions at the hospital, looking at all of the ways that we were contributing to emissions and where that was coming from so that we could focus better on reducing our emissions. And she had implemented a really great program on reducing emissions from commuting by encouraging non-single occupancy driving, so carpooling, active transport like cycling, public transportation. And then continuing after she left, our newer sustainability team members have also been working on decommissioning our natural gas stoves and heating systems, our steam boilers, and converting those over to electric. So the big two on this graph they were dealing with. One of the ones that I noticed, of course, right away was that anesthetic gases made up 7% of our total hospital emissions. And this is, of course, one of the clinical impacts here that we have. And in all of these emissions, we're looking at scope 1 and 2, which are direct and indirect emissions from hospital operations, but scope 3 emissions come from our supply chain, which is a very large problem and not captured in this particular graph, but something that, of course, we need to deal with as well. All of the emissions that come from producing and transporting and then disposing of all of the supplies that we use for healthcare delivery. I was surprised to see that anesthetic gases were represented on this pie chart so prominently at 7%, and I wondered what we could do about reducing these emissions. So I began to learn more about this and work together with my colleagues in my department to reduce the amount of emissions that we were responsible for in our delivery of healthcare to our patients. So why were anesthetic agents on this graph to begin with? Well, our inhaled anesthetic agents are greenhouse gases. This slide is an adaptation of a chart made by Naveen Nathan in a really great paper that he published several years ago. So highlighting that our waste anesthesia gases here are released into the environment. They're emitted directly out of our hospital systems. And at this point, there is not really any ability to scavenge these agents. So there's some technology in development, but it's not widely available yet. So most of the agents that we deliver to our patients are breathed back out and unchanged. Only about 5% are metabolized and go directly into the environment where they contribute to global warming, and some also deplete the ozone layer. So we know that this is occurring, and there are ways that we can reduce this. So I'll talk about those in a moment. So just a way to kind of keep this in perspective here, these are really strong greenhouse gases. Desflurane is the most potent. It has a very high global warming potential, which I'll explain in a moment. But one bottle of desflurane is equivalent in terms of its emissions and global warming potential to burning nearly 1,000 pounds of coal. So this is a really big problem. The emissions from our inhaled agents can be compared using our global warming potential over a 100-year time horizon. And so this is a common metric that's used to compare greenhouse gases. We know that carbon dioxide persists in the environment for hundreds, maybe thousands of years, and it is our standard to which we compare all other greenhouse gases. It has a global warming potential defined as 1, and all the other agents are compared to that. So when we compare our various inhaled agents, here listed isoflurane, sevoflurane, desflurane, and nitrous oxide, we can see that they have various global warming potentials here. And when we think about how much we need to use to provide an anesthetic for our patients, there's a varying amount because they have different potencies for anesthesia as well as different potencies for global warming potential. We can see how they relate to, say, driving an average car. So you can see that there's a big difference here. Isoflurane and sevoflurane have lower global warming potentials, and desflurane and nitrous oxide have higher global warming potentials. So delivering an anesthetic with desflurane at kind of standard doses to keep a patient asleep would be the equivalent of driving 190 miles in an average gas-powered car per hour of anesthesia. So that one is pretty obviously a high-impact agent and one that we can avoid. So we started looking at this in our own practice at Seattle Children's, and I got together with some colleagues to think about how we could change our practice and thinking about what the causes were for our higher emissions. So we looked at kind of various parts of the problem, and we thought, okay, in terms of the people working in our department, we didn't have a lot of awareness about this. I certainly didn't get this education in my training. It wasn't something that was on front of mind for us. We didn't really know what the issue was, and we work in a culture where there's just kind of a lot of disposable items. And we think, well, we need this for the patient, so we don't really need to think about the impact here. And that culture is changing. In terms of materials, we were using these high impact agents alongside the lower ones. So we were using nitrous oxide very routinely. We were using desflurane without any restriction. We also had equipment that wasn't really helping us be more efficient. So we didn't have access to the data in terms of how much we were emitting per case or per month or per person. And our anesthesia machines, this is getting a little technical here, they defaulted onto a high fresh gas flow, which is a less efficient way to deliver these medications and contributes to more waste without necessarily improving the patient experience. And then in terms of our processes in pediatric anesthesia, we use a lot of these gases because most kids don't tolerate or don't want an IV placed. And so they would get a mask or inhalation induction, which is using these gases to go off to sleep, usually at high concentrations and high rates of fresh gas flow. We didn't have standards. We do a lot of short cases that have high flows and high gas. So this was all contributing to our emissions here. So we thought about how we could approach this problem. And the first thing we did was really just start with education and socialization. We started to think about this issue, talk about it in our workroom. I brought some education to our trainees and to our nurse anesthetists. We integrated this into the curriculum for our residents and fellows. And we started talking about how we could, really avoid these high impact agents, desflurane and nitrous oxide. TIVA is an acronym for total intravenous anesthesia, which is using IV medications instead of the gases. It has a really nice safety profile. It's feasible and easy to do in many cases, and it has a much lower environmental impact. And then encouraging some of our older patients to get an IV placed, which would be, again, a way to avoid using the inhalation agents that have this high global warming potential. Low flow anesthesia is a concept that's been around for a long time, but it wasn't really in common use. And so now there are more education modules available, including this course put out by the APSF, the Anesthesia Patient Safety Foundation, teaching folks how to use low flow anesthesia. I talked a little bit about this already. Low flow anesthesia is a way to deliver the same concentration of anesthesia gas with less waste. So this is a really efficient way to use these greenhouse gases that we are emitting without wasting a lot of them. So we can still deliver enough anesthesia to our patients. So again, not compromising on patient care, but reducing our waste and reducing our emissions. There have been questions in the past about the safety of using low flow, but we know that it is safe. We can use different tools to help us provide low flow anesthesia, including decision support tools, flow wizards, pause buttons on our anesthesia machines, and education around this. It's important to know that this is safe. There had been questions in the past about using certain inhaled agents at low flow and the potential for toxicity or compounds that might be harmful building up in our anesthesia machine. But we know with modern systems that is not an issue. And a recent statement from the ASA came out in favor of low flow anesthesia, demonstrating and supporting its safety and its use. So this is something that all anesthesiologists should feel comfortable doing. The next thing that we did at Seattle Children's was introduce Project Spruce, which stands for Saving Our Planet by Reducing Carbon Emissions. And this project included the education and socialization, some practice constraints around low flow anesthesia, so changing our default fresh gas flows on the machine and removing desflurane vaporizers from our operating rooms so that the hurdle to use it was a little higher. And then we started to give direct data feedback to the team on how we were doing with our emissions. So we could see then all of us, how we were doing, how we were progressing as a group and as individuals. We were able to celebrate the lowest emitters and and learn from them so that all of us could do that kind of work and identify our highest emissions cases so that we could target our interventions further and say, okay, this is an area where we have the highest need for improvement. So Project Spruce really encompassed all of this, but the biggest part, I think, for us was having access to the data and giving that data feedback to the clinical team. We were able to track our emissions on a much finer scale. So the graph that I showed you at the very beginning was purchasing data. So we were able to see how many bottles of these gases did we buy each year. But what we were able to see using a software called Adaptix is how much emissions we were actually generating from our use in the operating room. And we could see this down to a case-by-case level, an individual clinician level, and a case type or surgery type level. So this is an average of our carbon dioxide equivalents from our inhaled anesthetics. And again, we can calculate this using those global warming potentials, which compare different greenhouse gases to one another, and calculate these averages out for all of our cases on a by minute basis. So we could say, regardless of if it's a 15-minute tonsillectomy versus a 6-hour spine surgery, we can see our emissions on average in kilograms of CO2 equivalents per minute of anesthesia delivered to normalize it and allow us to track it over time across all of our different case types. And we started out with higher emissions. So this is why we had 7% of our total hospital emissions. At our baseline, we were emitting about 0.26 kilograms of CO2 equivalents per minute of anesthesia delivered. With our introduction of socialization and education, we had a massive decrease. So that's our first instance of what's called special cause variation on this statistical process control chart, where we see a statistically significant signal here where we've had this reduction as a group. We removed those desflurane vaporizers from the operating rooms and then eventually removed it from our hospital formulary as we learned we did not need that medication to deliver safe anesthesia to our patients. We added some of those practice constraints that I talked about and support tools for low flow anesthesia, and then started giving our data feedback to the team. First every month, and then we reduced it to every quarter. And now you can see in our current state, we are about 10 times lower in terms of our average emissions than when we started. So we've made a lasting and profound decrease in our measured emissions in the operating room. This is at our main hospital where we take care of all sorts of patients ranging from preemie babies all the way up to young adults for all sorts of surgeries, including, things like ear tubes all the way up to heart surgeries. So this is a very broad range of cases and patients and anesthesia clinicians that are caring for these patients. And throughout all of that, we've been able to reduce our emissions. We can see by individual anesthesiologist. We can also see this by nurse anesthetist, resident, fellow, by case type or surgery type, all sorts by age group of patient, all sorts of metrics are available to us. And we can see, again, areas where we need to improve and areas where we've made a big change already. And I like this slide because it shows the variation in our practice at our baseline. So this is the same data on the previous slide, but now I've pivoted it and each dot represents one of my colleagues or myself. And so just pointing out a few folks here, I just have some examples of how people have changed their practice over the years. So anesthesiologist A was our highest emitter to start with. And this person, I talked to them and they used nitrous oxide really freely. They used desflurane kind of whenever they felt it was appropriate and necessary, which was a lot. And then as soon as they started learning about it and thinking, oh, okay, this is a practice I can change. I know what I'm doing in terms of emissions now. So I'm going to stop using desflurane so much and I'm going to reduce my flows and maybe phase out my nitrous oxide use. And so over the course of all of these interventions, that person reduced their emissions dramatically with all of these interventions. Anesthesiologist B was a little more resistant to the socialization and practice constraints. But when we started giving data feedback and there was some peer pressure, that person had their emissions reduced by about 50%. And then they retired from clinical practice. And so they're no longer on our current state. But by the end of their practice, their time as an anesthesiologist, they had reduced by 50% after years of doing things the same way. So all of us have capacity to change and reduce our emissions. And then anesthesiologist C was a really interesting case for me. This is someone I looked to as a role model for using IV anesthetics, which remember I said had much lower environmental impact. But what they were doing was still going to sleep with nitrous oxide with higher flows in the mask and only starting the IV anesthesia once the patient was asleep and the IV was placed. And during those first few minutes of the case, emitting so much in terms of greenhouse gases that they were still above average. But once they heard kind of what we were trying to do, learned a little bit more about it, stopped using nitrous oxide routinely, they became one of our very lowest emitters. So a real role model for all of us. And again, I make this so that we can learn from each other, so that we can look at our own improvement. None of this was, meant to embarrass anyone or punish anyone. There were never any consequences for high emissions, really just, using this data so that we can learn and improve together as a group. We saw a similar, really profound decrease at our ambulatory surgery center, where we do a lot of short cases. These are all day surgeries for healthier patients. And we had higher average emissions because, again, these are shorter cases. So we're emitting a lot at the beginning of the case when we have our patients go off to sleep with that inhalation induction. And so we had more room for improvement, again, had about a 10-fold reduction here over the course of all of these projects. And again, everyone has learned together how to do this and how to keep our patients safe and happy when they wake up. So part of the way that we made these big reductions was by reducing our nitrous oxide use. And you'll remember that the global warming potential for nitrous oxide is close to 300 times that of carbon dioxide. We tend to use it at high concentrations when we use it. So that's part of the reason it has such a high impact in healthcare. That high global warming potential plus used at high concentrations and tend to be at high fresh gas flows. So lots of waste, lots of emissions in a very short period of time. So this was our standard when I was in training. We were using nitrous oxide for nearly all of our patients at both the ambulatory surgery center and our main hospital. So that's at the top here. You can see our percent of cases where we're using nitrous. Once we started working on our education, socialization, and some of those constraints, we decreased that. And now we're using it, about 1% of the time. Really when it's something that's needed and we don't have a good clinical alternative. And then even when we are using it, we're using less of it because we're being more efficient with the lower fresh gas flows. We're maybe turning it off a little bit sooner in the phase of induction when we are starting our anesthetic for our patients. So even when we are using it now, we're using a lot less. And one thing that we found that was a kind of surprise when we were going through this project is with our decrease in clinical use of nitrous oxide, which is shown here as a total on this graph on the right, our total liters of nitrous oxide in the operating room, again, as I mentioned, have come down dramatically. We're not using it for 90% of our patients anymore. We're using it for maybe 1%. But what we saw was the amount of nitrous oxide that our hospital was purchasing was coming down at a much slower rate. And so this allowed us to identify that our system was really inefficient. The way that most hospitals and surgery centers deliver their nitrous oxide is through a central supply. So they have a big tank of nitrous oxide in a supply area, and then it's piped through the hospital behind our walls. And there are all sorts of connections and gauges and fittings that can loosen over time because of the small size of nitrous oxide as a gas. It's very difficult to maintain and keep a system completely gas tight. So we were losing most of the nitrous oxide that we were buying before it even reached patient care. So probably more than 90% of the nitrous oxide that we've purchased over the course of this project never even reached our patients. And we were buying it and wasting it. So this is, something that not only wastes money, but it significantly contributes to our emissions. So we are going through the process now of deactivating that central system in favor of using portable tanks that we can put either on the back of our anesthesia machine or on a cart that can be moved around, closed in between uses to really reduce the amount of waste. And so that project is ongoing and hopefully will be completed shortly. We're really fortunate to be able to share the results that we have at Seattle Children's. We published a paper, we presented this at conferences, and we had a lot of interest from other folks. I partnered together with Dr. Diane Gordon at Colorado Children's Hospital, who leads the special interest group in sustainability at the Society for Pediatric Anesthesia. And she was really encouraged by the work that we were doing. She's been working in this field for a long time. So together we founded the Project Spruce Consortium. So this is now a consortium of 12 plus hospitals, children's hospitals that have all banded together to do this kind of work. At Seattle Children's, we're still doing this work, but we've reached a steady state of our low emissions. We've reduced our inhaled anesthetic emissions by over 90%. And since we started this project, this represents over 2.3 million kilograms of CO2 equivalents saved in terms of our emissions. This is also fortunately saving our hospital a lot of money since we're wasting a lot less of these gases. We're being much more efficient with how we use them. So the hospital has been really happy, both for our emissions reduction as well as our cost savings with this. So you can see on this graph, there's a lot of data on here, but basically the bottom line here is that we used to spend over $250,000 a year on our volatile anesthetics. And last year, I just got this data, we spent just over $68,000. So, with the emissions reduction here and our efficiency work, we've saved about $900,000 in just our volatile anesthetic purchasing at our main hospital. So this is great news. The consortium has worked really well together to share the progress that we've made. And so these are some of the hospitals that have already achieved massive reductions in their emissions. So these are showing baseline emissions in terms of kilograms of CO2 equivalents per minute in orange, and then their current emissions as of last month in blue. So all of the participating hospitals in our project consortium have had dramatic reductions in their emissions. Our goal was a 50% reduction in emissions over 12 months, and nearly all the hospitals have already achieved that goal. And so we meet every month, we talk about the barriers that we face, we share our ideas. Folks are doing really exciting projects and challenges to their groups for Earth Month this month. And it's been really exciting to see how everyone is approaching this problem and how we can learn from each other. So it's really encouraging to see that, we're not just stopping at Seattle Children's, but we're really spreading out all over the world to implement this kind of work. Everyone in the consortium has reduced their nitrous oxide use. So I think this is really a trend that will take off in pediatric anesthesia and hopefully adult anesthesia as well, that we don't really need nitrous oxide for most of our patients. We can deliver great care without it. So this is, again, in baseline nitrous oxide percent of cases using it in orange, and then current as of last month in blue. So all of our consortium hospitals have reduced their nitrous oxide use significantly. I'll stop there. I want to say thank you for having me here. I'm really excited to be part of this event. Thank you to my mentors, Lynn Martin and Dan Lowe, and thank you to Adaptix for supporting this work, my collaborator, Diane Gordon, everyone at Seattle Children's and the anesthesia group who really started this work and showed how we can do it, the Project Spruce Consortium, and all of the amazing principal investigators at each of those hospitals. Thank you for doing this work and sharing your data. The sustainability team at Seattle Children's, and then the Cascadian Nitrous Oxide Collaborative have contributed as well. So I would be happy to take questions or any discussion at this point.
Liz, you talked a little bit about how you at Seattle Children's actually kind of started the project. Do you feel like that starting in the operating room for other organizations would be kind of a natural place to start because of similar kind of waste that you saw at Seattle Children's?
Yeah, absolutely. I think, anesthesia clinicians, anesthesiologists, we're leaders in the operating room. We are kind of, captain of this ship. We are known for, stopping the line for safety concerns. People look to us when there's a crisis. So I think, that definitely translates into the climate crisis. We can be leaders in this field as well. And there's a lot of room for improvement. I don't think I've met anyone at a hospital that says, oh, we're already the most efficient we can be. We already have reduced our flows so much. We've already eliminated, nitrous oxide and desflurane. Everyone has something that they can do. And through education, socialization, practice constraints, and then especially that data feedback, people are really excited to know what their emissions are, and they're really excited to see how they can improve. So yes, I think that, folks in the operating room, anesthesiologists and anesthesia clinicians in general have a great opportunity to be leaders in this and take on this kind of work wherever they are.
That's awesome. So I was thrilled to see your new updated information around cost reduction. And oftentimes sustainability comes with the assumption that there's added cost to a project. And, again, you have shown and demonstrated at Seattle Children's great results in reducing cost. Are you seeing that trend among the other cohort participants?
Yeah, we have. It's been really exciting, and actually, that's one of the ways that this project was supported at some of our hospitals in the consortium. They were able to say, we expect to see significant cost savings here. So, the hospital can then support this work and support the principal investigator to have time to do this project, have the software support, things like that to participate, because we see such dramatic cost savings with our improved efficiency. And again, I want to point out this is not a reduction in the amount of anesthesia we're giving to our patients. That's a common misconception. We're still able to deliver the same amount of anesthesia to keep our patients safe and asleep during their procedures, but we're reducing the waste. So that allows us to save on those costs. So just imagine how much waste there was at Seattle Children's before we started this project, because we were using high flows and we were using the more expensive agents. And now, we've shown we don't need to do that. Our patients still do really well. Of course, we've used the Adaptix software to track a lot of balancing measures as well to make sure that our patients are still satisfied, that they're still having good outcomes, that we're not seeing any unintended consequences of this work.
That's great. That's great. So what kind of reaction did you get from the overall clinical team, your colleagues and others, when you first introduced Project Spruce to Seattle Children's?
Yeah, it was mixed. Most people were really excited and wanted to know how they could change their practice. And there were a few people who already knew about this problem and they said, oh yeah, one of my colleagues who did the TIVA every time. So he knew about it and he was excited to change further once he figured out, oh, there's still things I can do to improve. So people really do gravitate to data once they started seeing their own emissions and seeing, oh, there's somebody who has lower emissions than me. I'm going to go ask them how they do that. I want to actually watch what they do. How are they achieving this? So then we can really just continue to improve and iterate. And there's always something you can do to improve. And I think that attitude and that kind of mindset of continuous quality improvement is something that anesthesiologists and anesthesia clinicians are really drawn to. It's something that we've worked on in other areas of quality improvement. So this really just, I think, naturally fits from that. And I think our team knows about that kind of quality improvement work and understands how that functions in our system, and is overall really eager and excited to participate.
That's awesome. How has the utilizing of the EMR data and the fresh flow information coming through your EMR, and now kind of through the platform of Adaptix, how has that supported the decision making and your behavior throughout this entire project?
Yeah, that's a great question. So, having the data, as I've been saying this whole time, is, it's super critical. So we can motivate folks by showing them their data, but we can also track, we need to have that data to track what we're doing and to show, okay, yes, this is, we're making these improvements. We are decreasing our emissions. We're doing that safely, so we can track all of these other balancing measures. And then it allowed us also to find this discrepancy between our purchased nitrous oxide and our delivered nitrous oxide. And we never would have had that without the data. The math that we use to calculate our carbon dioxide equivalents is fairly straightforward, but we do need data from the EMR, and we collect that data. Most, systems have an electronic medical record for their anesthesia portion of the case, and we have all of this data minute by minute. What fresh gas flows are we using? What agents are we using, so that we can total it up? And there are many different ways to do this. And some of the anesthesia machines will actually output how many milliliters of sevoflurane, you used for the case, for example. And, Epic has some tools in place to track this as well. So there are many ways to do this. We're lucky to have Adaptix at Seattle Children's, and that has allowed, really all of us to access this data in a really user-friendly way. Before I had access to this data, I was relying on a data analyst to send me reports, and that was slow. And it was difficult for me to really get into the nitty-gritty of it and see all of these balancing measures, look at all of our metrics, and really identify our areas where we needed to improve. So having Adaptix, that user-friendly interface has been really helpful. But yeah, I think any way of getting this data is helpful. People need to see it. We're big fans of Adaptix at Seattle Children's.
That's awesome. Last question. How can sustainability officers and green teams and other clinicians who are really passionate like you are, Dr. Hansen, how can they collaborate? What could they do to participate in your cohort?
Yeah, so we have kind of ongoing recruitment for Project Spruce Consortium. We have our initial members that have already made their reductions. We're still meeting, we're still welcoming new members. So if you are an anesthesiologist, please reach out. We're happy to talk and involve you in the work that we're doing. We're always happy to share what's going on, to learn from each other. So please reach out. And sustainability teams, there are so many areas in the hospital where we can focus on this. So I would say, look at where you work. If you're a clinician who's not in the operating room, again, look at what's in your clinical environment and see what areas, you can improve on. I'm working with a radiologist who's looking at reducing the amount of waste with IV contrast for MRIs. So that's an area, she's really passionate about. I've been working with a dentist who's using nitrous oxide in, their clinical dentistry for pediatrics as well as adults, and working on how they can reduce the waste there. So there are so many areas where people can focus in on this. So whatever you can do, you should do. And of course, happy to reach out or happy to connect with anybody who has questions. I would encourage folks to look at the resources. At the beginning of the presentation, I had a lot of different organizations up there. And so all of those have great information and suggestions for where to start.
And I think you and Dr. Gordon also have a website. Could you tell the audience about your website?
Do. Yeah. So our Project Spruce, it's www.projectspruceforest.com. I think if you Google it, you might be able to find it, and we can probably include it at the end here. And yeah, it's got a lot of links and information and a way to contact us as well.
That is great. Thank you so much for your time today. We are so appreciative of the great work that you're doing to save the planet. We also want to thank Global Health and Purpose Summit for having us today. And we welcome questions and engagement. So please reach out to us. Thank you so much.
Thank you.